Cost of these immunotherapeutic agents are, when you see the sticker price, are very shocking, and I can understand that from anybody's perspective. However, the amount of benefit that these agents give patients, we're not talking weeks, we're not talking months, we're talking years and perhaps decades and a long amount of time, so that if we're averaging the cost of these agents over the patient's lifespan, I think the upfront sticker shock gets a little bit reduced. But I do think cost is an issue, and we do need to do a better way of maximizing the benefit of these drugs and reducing the cost. And one of the biggest unanswered questions, I think, with helping to both curtail the cost and the toxicity of these drugs is how long should we be using these drugs? Nobody really knows. All the clinical studies that we participated in the early time required that we keep patients on for up to a year, or sometimes even longer, 2 years, when patients were doing quite well. And we didn't want to stop because there was no parachute for the patient to get back on the study if they didn't do well. And we also just didn't know what was going to happen if patients were coming off, so everybody was appropriately cautious. Now I think with 5 years of follow-up, 3 to 5 years depending on the drug, we know that most of these responses are durable. Sure, there are a couple patients that might recur, and at least the data that I've seen, the patients that do recur after responding can respond again to re-challenging. So the risk of stopping seems to be pretty low as long as we are, can restart. So if we can design some studies that would maybe address the question of how long is long enough, maybe 3 months, maybe 6 months, maybe 9 months. I don't know the answer, but if we could prospectively look at that, I think that could help not only with cost, but cost is very important, but these drugs still have some toxicities. So, we don't want to unnecessarily give drugs to patients who don't need them that long.